Welcome to Stanford Medcast, the podcast from Stanford CME that brings you the latest insights from the world's leading physicians and scientists. If you're joining us for the first time, be sure to subscribe on Apple Podcasts, Amazon Music, Spotify, or YouTube to stay updated with our newest episodes. I am your host, Dr. Ruth Adewuya. Today I will be chatting with Dr. Heike Daldrup-Link. Dr. Heike Daldrup-Link is a professor of radiology and pediatrics at Stanford University School of Medicine, where she leads groundbreaking research in pediatric oncology imaging. As a leading physician scientist, Dr. Daldrup-Link is renowned for her pioneering work in applying nanotechnology to enhance diagnostic imaging techniques for children with cancer. Her research focuses on developing innovative, non-invasive imaging agents that improve cancer detection and reduce the need for radiation, making cancer diagnostics safer for young children. Through her work at Stanford, she combines her expertise in molecular imaging, radiology, and oncology to push the boundaries of how clinicians diagnose, monitor, and treat pediatric cancers. Over the past 10 years, Dr. Daldrup-Link's team has received 77 honors and awards for innovative cellular imaging research. Thank you so much, Dr. Daldrup-Link, for chatting with me today on the podcast.
Thank you so much for having me.
I'm excited to chat with you about this emerging tech, nanotechnology, and its utilization in clinical medicine. For listeners who are less familiar with what this is, can you talk about what is nanotechnology in the context of medical imaging and what makes it particularly exciting for pediatric oncology?
Nanotechnology in general describes extremely small materials and devices in the order of 1 to 100 nanometers. In the context of medical imaging, we mostly talk about new contrast agents, which are a little larger than the usual molecules that we use as contrast agents in the clinic nowadays. We can use them for improving medical imaging diagnosis, and we can also use them as so-called theranostics, combined diagnostic and therapeutic drugs.
That's a new term to me, theranostics. When you talk about these nanoparticles, can you explain how they work within the body for imaging purposes and how they do differ from traditional imaging agents?
There are different types of nanoparticles, and our group specifically works with iron oxide nanoparticles. These nanoparticles contain iron, which we can detect with an MRI scanner. They provide a signal on our images. When we inject these iron oxide nanoparticles, because they are relatively large, they stay in blood vessels for a relatively long time, and that allows us to generate very high resolution vascular imaging studies. Over time, these nanoparticles accumulate in various organs. We can target them so that they find a specific organ where we want them to accumulate. For example, in tumors, they slowly accumulate through a process where they penetrate the vessels and then accumulate in the tumor tissue. We can better image vessels, we can target certain organs within the bodies, and we can also specifically image tumors.
This is quite interesting. If I'm hearing you correctly, it's the property of these molecules that make them beneficial in oncology because they bind to the tumor cells. What are the things that you can appreciate because of this binding?
We have non-targeted nanoparticles, and these are actually more commonly used. They just behave differently to standard contrast agents because of their large size. Initially, they stay in the blood pool that allows us to image vessels with very high detail. Then they leak across tumor microvessels into tumors, and there they are phagocytosed by immune cells. That allows us conclusions about the immune cell composition in the tumor. Now, we can also decorate the nanoparticles with antibodies or any other target that cancer cells can recognize, which then specifically allows the nanoparticles to accumulate in the tumor tissue. That applies specifically to the theranostics. We have some nanoparticles that we attach to therapeutic drugs. We can attach them with a linker that is cleaved by specific enzymes that are only present in the tumor tissue and not anywhere else. That then leads to therapeutic drugs that have very little or no side effects and that are only activated in the tumor tissue. When the nanoparticle reaches the tumor tissue, the cargo is cleaved by the enzyme that is there. The therapeutic drug is only released in the tumor and not anywhere else.
It's a tremendous opportunity for personalized medicine in terms of allowing clinicians to identify the tumors and treat them in a highly specific manner, and ultimately improving patient outcomes in such a way that might not be seen through conventional treatment. If we talk specifically about how are we improving the precision of cancer imaging, especially for younger patients who may be more vulnerable to radiation and invasive procedures?
I think we have to differentiate what we have available in the clinic right now and then what is in the pipeline of research. If we look at what we have right now, these are the non-targeted nanoparticles. We specifically use an iron oxide compound that is FDA approved as an iron supplement. We use this iron supplement off-label as a contrast agent for MRI. In MRI, you might have heard about the gadolinium-based contrast agents. There are some concerns because gadolinium is a heavy metal and it can deposit in certain organs, including in the brain. And so there's some concern about long-term retention of gadolinium in certain patients. Using an iron supplement from a safety perspective, the iron is incorporated into the body's reticuloendothelial system in liver, spleen, and bone marrow. It is metabolized there and completely eliminated over time. Any agent can have a side effect, so these nanoparticles can sometimes lead to allergic reactions. I think it's very difficult to say there's the ultimate safe procedure. Any procedure or any drug has pros and cons. With regards to the nanoparticles, the big pro is that it can be completely metabolized. We can use it in patients with renal insufficiency for whom gadolinium contrast agents or iodinated contrast agents are a problem because the kidneys cannot eliminate them. We can make a personalized plan for the patient to choose the best option for their specific condition.
I appreciate your comment about safety. It's this check and balance of what would be slightly safer. I'm curious about whether you have seen this reduction in side effects compared to conventional imaging methods.
I have seen different side effects. For the current clinical contrast agents that we have, they are iodine-based contrast agents. These are for CT imaging, which involves radiation exposure. The iodinated contrast agents are usually given in patients who have an intact function of their kidney, because these contrast agents are eliminated through the kidney. In patients who have a problem with their kidney function, nanoparticles will be a great alternative because they are taken up by liver, spleen, and bone marrow and then metabolized there. They are not eliminated through the kidneys. It's similar for the gadolinium-based contrast agents for MRI. There's a problem if the patient has a renal insufficiency, because again, these standard clinical contrast agents are eliminated through the kidney. If the kidney doesn't function, then they are not properly excreted, and that then can cause problems. All of these contrast agents can lead to allergic reactions. The nanoparticles overall statistically can have a little higher frequency of allergic reactions compared to the gadolinium chelates, and approximately the same or similar risk of allergic reactions to iodinated contrast agents. We specifically check our patients for any history of allergic reactions. We make a personalized decision and avoid it if a patient has any history of severe allergic reactions.
Can you expound on what you typically see there when you talk about allergic reactions to the nanoparticles?
There are a number of different reactions. These iron oxide nanoparticles have a carboxymethyldextran coat that is a dextran derivative. A lot of people have allergies against dextran. We look for such history if that is present. We know that the true allergic reaction against these nanoparticles is essentially a dextran allergy. There are new research efforts ongoing to develop new nanoparticles that have a different code to have a much risk of allergic reactions. In addition to this true allergic reaction, iron supplements can cause something that we call a pseudo-allergy. It presents with similar symptoms, but is not a true allergy, but a complement reaction. And that happens when these nanoparticles are injected into the bloodstream too fast. If we deliver the nanoparticles too fast to the bloodstream, then complement factors in the blood can be activated, and that can lead to an allergy-like reaction. To minimize that effect, the FDA actually has issued a strong recommendation that nanoparticles have to be infused over at least 20 minutes. So the body has the advantage to capture these nanoparticles and transport them properly. We also have these protocols in place in our clinic. I have not seen any allergy-like reaction in our patients. We had one patient who had a light form of an allergic reaction, and that was properly treated and didn't lead to any major short-term or long-term problems.
It's clear that nanotechnology holds this immense potential for advancing patient care, but adopting it in a responsible way also means addressing some of these side effects that you've mentioned. The ongoing research that you and your team, and I think countless others, are doing are obviously some of those crucial steps to maximize the benefits of nanotechnology while really ensuring that there is safety around it. I want to take a step back and ask you how you came to focus on nanotechnology within pediatric oncology imaging.
I took quite a journey, as you might hear from my accent. I'm originally from Germany, actually, and I went to medical school in Germany. While I was there, the first MRI contrast agents were developed. Gadolinium DTPA, the first MRI contrast agent, was patented in 1981. And then the first human patient received this gadolinium-based contrast agent in Berlin in 1983. And shortly after that, the first human volunteer received the drug in Berlin in 1983 because it was developed there. And then actually the first patient underwent an gadolinium-enhanced imaging study in 1983 at the Hammersmith Hospital in London. And from there, actually, research centers around the world, including UCSF, were involved in the development of these gadolinium-based contrast agents, which ultimately brought me to San Francisco. In the process, since I was involved in very early developments of MRI contrast agents, I also got involved in development of nanoparticle-based alternatives. So through my career, I was involved in many phase 1 to phase 3 clinical trials for MRI contrast agents, including gadolinium-based contrast agents. I believe I was involved in clinical trials for every nanoparticle for MRI that was ever used in the clinic. I got a very good foundation with two nanoparticle studies. I'm really thrilled to share that knowledge now in an institution like Stanford, which has immense resources to advance this field.
Your journey is incredible. It's almost like you followed the journey of imaging from Germany and you're continuing to develop it. And that's just incredible. As someone who has this deep history into the evolution of imaging, I'm curious if you could share a recent case or a study where nanotechnology has really played a pivotal role in the diagnosing or monitoring of pediatric cancer.
Currently in the clinic, we start with the more simple applications. Applications range from vascular imaging, delineating tumors better, and also imaging specific immune cells in the tumor tissue. The most common application is vascular imaging. We inject the nanoparticles, they stay in the blood pool much longer than the current small molecular probes. Therefore, we can see the vessels to much greater detail than with standard contrast agents. We use this technique on a regular basis for planning of a liver transplant. Patients who have liver tumors that involve the entire liver and who need a liver transplant, in order to plan the surgery, we need to know where the vessels are exactly. And in young children, these vessels and their branches can be really small. Using the nanoparticles can help us immensely to see the anatomy. That can help with surgery planning and with an improved and more efficient process for a liver transplant. We can use nanoparticles to better see tumors. That can help to guide biopsies or help us to follow these tumors before and after treatment. Yet more experiment for which we examined very few patients, imaging immune cells in the tumor tissue. We have nanoparticles that are taken up by tumor-associated macrophages, immune cells in the tumor tissue, and some immunotherapies. With nanoparticles, we can see this activation of immune cells in the tumor tissue. And these immune cells, essentially, they fight the cancer cells.
Your response really highlights some of these promising developments in pediatric oncology imaging when it relates to detection and treatment planning. I think one of the things that I heard from you is how by the improved imaging of vascular structures in tumors, it could play a key role, especially in the pediatric population where these networks are so complex, that it really provides this opportunity to shift towards this less disruptive and more targeted interventions and really enhancing diagnosis precision, which is like just so exciting. One of the things that you mentioned is that you have some applications in clinic, but you have these experimental things that are still being researched. What does the pathway look like for integrating these innovations that are experimental into clinical practice?
The nanoparticles that we currently use, fortunately, are FDA approved as an iron supplement for the treatment of anemia. A lot of safety data are already available for these kind of nanoparticles. And for my specific experimental applications, I applied for an IND with the FDA, an investigational new drug application. This is, from an administrative point of view, a little more straightforward if the drug is already FDA approved. So we apply for off-label use of an already FDA approved agent. And I have to say, currently, these iron supplements are approved for adults. And so the off-label use is number one for imaging and number two for applications in the pediatric population. Other nanoparticles that are currently in development, they have to go through the entire IND process. So they start with phase 0, phase 1 clinical trials with dose escalating studies where we check the safety and toxicity of the agents, starting with very low doses and then slowly increasing until we find the lowest possible dose that leads to a signal on our MR images. And then from there, we have to apply to the FDA for subsequent studies. Those clinical trials for new agents are often driven by companies because they are very administrative and time and cost intensive, and usually only companies have the resources to do that. There is at least one company currently that is very active in this field to advance new nanoparticles with this improved coating that I mentioned earlier. They just completed a phase 2 clinical trial in adult patients with liver tumors. This will be an agent that will be specifically FDA approved as a contrast agent. We wouldn't use it off-label anymore, but it would be, the purpose of this agent would be that it's a contrast agent. And so we have high hopes for that agent because that would make it much easier to use than through an off-label use.
With this technology being relatively new, are there any ethical considerations around using nanoparticles in children, and how do you approach these concerns?
With my experimental studies, we do that through an IRB protocol. An ethical committee reviewed what we want to do, and they provided input and then ultimately approved the study. We have a consent form. We meet with parents and the patient and try to explain as best as possible what the advantages and disadvantages are of a nanoparticle-based study. Then the patients sign an informed consent. I do believe that it's very important to explain in much detail the pros and cons of the potential advantages and potential risks of nanoparticle-based diagnostics and therapies so that patients and parents can make an informed decision. At Stanford, when we have children who can understand the procedure, we do obtain a consent from the parents because they make the decision, and we also obtain what is called an assent from the child. The parents decide, and the child also decides if they want to participate or not.
I think that's incredible that there's this process of transparent communication with the patients and for pediatric population with the parent and the actual child to make sure that they're fully informed of the implications of the interventions that they will be going through. I meant to ask you this earlier. Are there any negative impacts on the clinicians in any way of adopting nanotechnology or utilizing nanotechnology in medical spaces?
Yeah, of course, for any new technology, initially the whole workflow is much longer because we have the consent procedure. On the clinical side, it's really important to define which questions can we answer with the technology at hand and which questions require this new technology. Oftentimes, when you have a new tool at your hand, you want to use it for everything. In medicine, it's really important to think this through very carefully and define areas where this can be helpful and areas maybe where the standard technology is good enough.
You're spot on about the fact that there seems to be a specialized nature of nanotechnology, and this would require an upskilling for clinicians to understand when and how to administer therapy safely. Can you talk a little bit about the accessibility issues surrounding this?
I'm a physician scientist, so I do not know the actual costs that come out in the end. Currently, for our clinical trials that my group is conducting, those are funded by the National Cancer Institute. And so the National Cancer Institute funds the entire study. So there are no costs to the patient. Once these technologies get into the clinic, of course, then eventually the patient would be billed. I do believe there is a risk with new technologies which can be more expensive that has downstream implications for the cost, both for the insurance and perhaps also for the patient.
I appreciate your perspective and fully realize that this is a little bit outside of your wheelhouse, but I think that perspective is important for our listeners to understand the cost of new technologies. We're fortunate. We sit at Stanford and some of our patients will have access to these technologies, but over time, how will these new technologies actually be available in other areas?
For patients who are interested to participate in a clinical trial, any clinical trial for a medical condition, they can go online on clinicaltrials.gov. And that is a website by the National Institute of Health that lists all clinical trials everywhere in the country. There, patients can find clinical trials which most of the time cover all the costs for a treatment. And these clinical trials are open to everyone. From there, make an informed decision. This is a resource that is open to everyone. I would highly recommend that interested listeners here might want to check it out because I think it's a fantastic resource.
I think that's an excellent point and a good resource to be aware of. When we talked about your specific research, which uses an iron supplement that is already FDA approved, there's a clearer pathway in terms of understanding the long-term health effects. Can you talk a little bit about others that don't have that same situation? Can you foresee any potential long-term health effects of nanoparticles in pediatric patients?
With current research, there's a lot of emphasis on generating a good image contrast with nanoparticles, focusing on achieving accumulation of nanoparticles in certain tumors. There is often not as much emphasis on the metabolism of these drugs. I think this is really crucial, even in an early phase, because nanoparticle would not be viable if it wouldn't get metabolized and eliminated from the body. We have to make sure that within a certain time period, these nanoparticles are completely metabolized and eliminated. Sometimes nanoparticles or other contrast agents can accumulate in certain tissues. If they are not metabolized there, then they can cause an immune response or an inflammatory reaction that can then lead to tissue problems. This has been described for the gadolinium chelates, for example, in patients with renal insufficiency. The gadolinium can be deposited in the skin and then cause a skin sclerosis, thickening and hardening of the skin, which certainly we want to avoid. Some nanoparticles are so small that they can actually be eliminated. If that is the case, then they might appear in wastewater and could have an environmental impact. So that is a very important issue as well that we have to be aware of.
Nanotechnology does offer this potential to enhance precision in tumor detection, and that we can leverage it to visualize vasculature and help clinicians deliver more personalized care, but also the realization that there's still more research to be done in terms of the metabolism specifically, but also the impact to environment. To wrap up our conversation, as someone who's been part of this imaging journey for a long time, what do you hope will be the biggest breakthroughs in pediatric oncology imaging in the next 5 to 10 years?
One big part, artificial intelligence applications currently. So that's everywhere. That's a huge area of development. We are fortunate to work with a very talented computer scientist in our team. And some tiny little aspect where the nanoparticles can come in here is that they provide a very steady contrast enhancement over time. We don't have as much variation in the images compared to a contrast agent that provides a short peak enhancement and then decreasing enhancement of tissues so that every image looks a little different. So that can help with computer post-processing also. Application are theranostics. The underlying idea is that if I can already see where a drug is going and I see that it accumulates in the tumor tissue, why not use it as a carrier or Trojan horse to shut drug into the tumor tissue? And that would also allow me to monitor the efficacy of certain therapies. I believe that theranostics is a big new area. Another big area are cancer immunotherapies. Here, we imagers are trying to develop more and more sophisticated approaches that we can image different populations of immune cells in the body. The nanoparticles can also help us with that, as can many other imaging techniques as well.
Really exciting work that is happening in this field, and exciting to see the promise of a future that leverages this technology. Thank you so much for chatting with me today.
Thank you. It was a great pleasure.
This episode was brought to you by Stanford CME. To claim CME for listening to this episode, click on the Claim CME link below or visit medcast.stanford.edu. Check back for new episodes by subscribing to Stanford Medcast wherever you listen to podcasts.